In a world where voices are often silenced and stories go untold, one podcast is daring to break that silence. Global Health Uncensored. Join me as we dissect the untold stories of global health, where no topic is off limits and truth is sought after with relentless curiosity. From the corridors of power to the most remote corners of the earth, we will uncover the challenges, celebrate the triumphs, and shine light on the innovations shaping our world. Global Health Uncensored is a movement towards a healthier, more informed world. Be a part of the conversation. Listen, learn, and lend your voice to the global health revolution. This is where the voices of experts and leaders illuminate the path to understanding global health like never before. This is Global Health Uncensored with your host, Dr. Banda Khalifa. See you in our new episodes. Welcome, everybody, to a very special episode of Global Health Uncensored. On this episode, we are going to peel back the layers of global health to reveal the challenges and triumphs and the untold stories that shape our world, especially in the context of Africa. Today, we are incredibly honored to host a remarkable figure in the field of global health. She's a visionary leader and an advocate for health equity, with a career spanning over 3 decades across continents, from England to Kenya to Ethiopia, Nigeria, and the rest. Dr. Ebere has been at the forefront of medical and public health practice, specializing in health security, health systems, and the crucial development of leadership, especially among women in the health sector. Her work embodies the pursuit of a more equitable global health landscape. I would rather let her speak to her numerous accolades. Join us as we explore these questions and more to uncover the experiences and passions that have guided her distinguished career. So this episode is to understand the mechanisms of global health, as well as be inspired by the personal dedication and vision it takes to reimagine what's possible for the future of global health. So without further ado, let me dive straight into our conversation with Dr. Ebere. Welcome, Dr. Ebere, to the Global Health Uncensored.
Thank you very much. It's a pleasure to be here.
Yeah,
I'm a big fan of this podcast.
we are all a big fan of your work. I mean, you're doing an incredible job in the field. So it's wonderful to finally have you share a conversation with us. But before we dive into the broader themes of our discussion, I'd love to learn more about your personal journey in the field of global health, your experiences. I believe these will be incredibly valuable to understanding the the complexities and the challenges within the domain. So, by way of introduction, could you share some insights into your early life and how those experiences influence your decision to pursue a career in public health?
Okay, so again, thank you for having me. It's such an honor to be on this podcast. Right, where to start? So, I was born in the UK to Nigerian parents. I was born just at the beginning of the Nigerian Civil War, the Biafran War, and because my father was in the UK for postgraduate training, and we returned to Nigeria shortly after the war ended, to because my dad wanted to contribute to rebuilding the country after the war. So even though I was born in England, I all my formative years were in Nigeria. I grew up in Nigeria. what some Nigerians will recognize as an ABU, which is an Aba brought up. I grew up in a small, not that small, commercial town in the southeast of Nigeria. And my father practiced medicine there. He grew up there as a child, returned there as a medical practitioner, and he practiced medicine there for almost 50 years. He retired in his 80s. So I grew up in a household with a medical practitioner. My mother was my first feminist role model, although she would actually not identify herself as a feminist. But she was the first person to demonstrate to us that the women can occupy their space and take a leadership role in their professional space, as well as in be a homemaker and a parent and to lead the communities that they belong to. So I grew up in Nigeria, and that, as you all know, we Nigerians we grow up believing that we can do anything.
Yeah.
That is the Nigerian default position. And the interesting thing was growing up in Nigeria, everybody who did everything is Black. So like Chimamanda, I didn't realize that being Black was an issue until I left Nigeria. Because I knew people who were in charge of everything who were Black people, Nigerians. So it was actually moving abroad into the UK for my postgraduate training via Trinidad and Tobago, actually, was the first experience of, the color of my skin is supposed to be a barrier. But before getting to then, I had already experienced the perception of women in Nigeria as being less than men. That was, like I said, that was not the experience in my home, but it was one that I came across very quickly and consistently in academia and education and workplace. So in terms of how my early years informed where I am, what I do today, I actually didn't realize that until in hindsight. When I was about 10, I believe, or a little younger, we had a cousin come to stay with us for a holiday. And while she was with us, she was diagnosed with tuberculosis. And up till that point, it had never even I recognized the privilege in growing up in the family I had with the opportunities I had, because TB as something that would affect someone like me had never occurred to us. So we all had to get screened, as a contact tracing and stuff like that. And I was totally fascinated by this is medicine. You actually go to people and know where they came from and where they live. It was totally fascinating. And it sort of parked at the back of my mind. And it wasn't until I was actually in clinical practice as a junior doctor in the UK, and I started getting a little frustrated about we're treating patients. They're coming in with the same problems. We treat them, they go out, they come in again. And why aren't we asking about the social factors, the other factors in their lives that might influence how we prevent or how they manage their diseases? And so I started thinking, I knew I didn't want to stay in clinical medicine, but I didn't know what it was I wanted to do. And this is one of the reasons why the Liverpool School of Tropical Medicine is one of the educational institutions I'm most happy to be associated with. I went to the LSTM to do the diploma in tropical medicine and had the privilege of attending a series of lectures by Professor Adito Kumbo Lucas. He's now passed, who was a professor of community medicine, as it was called at the time. And he talked to us about communicable disease control. And I went, that's it. That's what I want to do. I want to figure out how to stop engage with society and community to stop these problems that we're having. And it clicked back to that early experience with TB. And as it happened, my clinical practice at the time was mostly in infectious diseases and tuberculosis. And then I went into public health, almost obsessively focused on TB. I'm still obsessively focused on TB. And I think, and I always challenge people, say, if you really want to address health and health equity, solve TB. Because it touches on every facet of the human existence. And the challenges of TB are the challenges of the human existence. So that's kind of how I ended up going into public health, specializing in communicable disease control. from communicable disease control, new emerging infections, zoonosis, and of course, that then morphs into health protection, emergency preparedness response, and that just sort of morphs into global health. Because I came to the view that why am I working in the UK addressing this issue? They have lots of people who can do this. I should actually refocus on my part of the world where these challenges are as significant, if not more so, but the resources to address it are less. And then, of course, threaded through all this is that experience of initially gender discrimination, and then when I was working in the UK, gender and race discrimination, or as they choose to call it these days, disparities. It's misogyny and racism. That's calling it what it is. And the underrepresentation of people who look like me in leadership positions. And again, back to TB. TB is a disease that demonstrates the challenge of equity in health.
Yeah.
And I kept thinking, so why are we trying to solve to address equity when the system is designed to maintain that status quo? If groups of individuals are not represented in shaping, designing, leading those systems, then you're never actually going to change the circumstance, the status quo, because you cannot rely on other people to always speak for others. You've got, and if there is an opportunity, and there's no reason why there shouldn't be, for everybody to contribute to the decisions that shape the systems that work for them. So that's kind of what got me to what I do today and the things that I care about. And all through that is really around equity.
Okay, I think that has been an interesting journey and motivation, being born in the UK, going back to Nigeria, and coming back in the diaspora kind of gives you a different perspective. I always say that once you stay in any part of Africa, the way you think is quite different from those who grew up entirely in the West or in the diaspora. So that kind of gives you a different perspective. And for as a Nigerian, as having worked and being in a class with Nigerians, I always feel that I can do spirit in it, and that's one thing that I truly like about that part of being Nigerian. So thank you so much for sharing with us your journey, your passion, and how this has motivated you. So it seems like you've had a very extensive work in the field, but throughout your experiences, can you share some of the pivotal moments or key influences in your decision to specialize in health equity, for example, leadership and development, and doing so, if you can help share how the field has evolved?
So the first leadership development program I had the opportunity to participate was put on by the UK's National Health Service. Must have been probably 20 years ago or more. And I remember that was my first experience of having a 360-degree appraisal. And it wasn't a very positive experience in that the feedback I got was effectively to be less me. I got some recommendation about you are aggressive, you are too outspoken, the usual things as angry black woman type of tropes. And the interesting thing for me there was that like I said, it was my first experience of that sort of training, and I thought there must be something. Let me try and be less me. Let me be different. Let me be this model of leadership that I was told is the thing to be. And within a few weeks of trying that, a group of my colleagues actually did a delegation to come and check if I was all right, because I wasn't being myself. And so then speaking to my boss at the time, I said, look, this was why. And she took a look at this and said, this is absolute rubbish. there is nothing wrong with being you, and how you are not just aggressive. You're very clear and assertive. She gave me some constructive feedback that countered the one I'd been given by professional appraisal people who didn't actually understand or hadn't even tried to understand the cultural context that I was operating within. So I remember reflecting on that and thinking that if, I had this sort of negative experience. Now, this is, leadership program has been rolled out across the country at the time. And as I learned, it was a global movement at the time. What's other people's experiences? I actually went to a point of access and asked, well, have you done this? Are you doing this leadership program? Who are the leadership models that you get told to emulate? What are you being told to do? And I found out that, first of all, there was a lack of models that looked like us. And I make no apologies by specifically focusing on Black women at the time. We were seen as not appropriate for leadership, and we had to change in order to be. You had leadership potential, but you had to change. And I thought, this is odd and this is strange. Before that, I confess I actually didn't know that mentorship was a thing. I had, in my public health training, had intentionally sought out women who were doing the job I wanted to do and approached them and said, can you support me and help me become what you do?
Mm-hmm.
I didn't know that was mentorship. And I'm very proud of to have been mentored by two dynamic women, not black, because at that time I don't recall that there were many black women in consultants in public health space. I was working in communications control at the time. But these were women who everybody had accused of the same thing I was being accused of: being too loud, being too confident, being too assertive. And they mentored me to be comfortable to be myself, and that was a legitimate part of the public leadership ecosystem. But on the back of that, I started saying, if I didn't see people like me, and the next generation are not seeing people like me. So we started sort of informally, started trying to sort of build networks and offer support to people who were on the same journey, and to pull other people together and say, you really should actually share what you do so that others can learn from it. And that's kind of how I got into the sort of leadership development part of my role, and recognizing, again, linking that back to equity, because if you change the makeup of the people in the room when the issues are being addressed, are discussed, and solutions are being put forward, you change the nature of the solutions that are being brought forward, and you actually increase the likelihood that you'll get the right solutions for the challenges that we're facing. And I found this most significant in, back again, TB. I was then leading a regional TB program, and I had the annual conference, the first time that I invited a TB patient to talk to a room full of almost exclusively men who were respiratory physicians who specialized TB. It was a young woman in her 20s at the time who'd suffered from extrapulmonary tuberculosis, and for years after that, I had clinicians who attended our conference say to me, that was the first time I'd heard it from the patient's perspective. These are people who work with TB for years. And again, that came back to the fact that if we are trying to solve the problems without with one hand tied behind our backs and without the knowledge and the experience of the people who we say we're working for. And so in everything I do, and I've done since then, I'm always looking around the room and saying, who isn't here? Who isn't speaking? Who are we solving this problem for? And also reminding myself that just because I'm in the room doesn't mean that I'm representing the entire ecosystem or the represented. I should also ask myself that question. Who's not here? Whose voice isn't heard? Whose perspective are we missing? And I think that's what drives me is every now and then I've written, you write a bit of thing and say, who's not here? Whose perspective am I considered? and then go and rewrite it. Or get someone else to say, can you look at this and say, what I've not considered? And I think that humility in recognizing that no matter how much experience you have, you cannot be confident that you can speak for everybody or the various perspectives that should be considered, helps you to build better systems and to build better solutions and to be intentional about inclusion and representation. I was use a one word to summarize I would call it the health architecture on the continent, and I would use neglected or orphaned. I think orphaned,
Mm-hmm.
and I use the term orphaned because nobody owns it. Nobody takes responsibility for the African for health experience on the continent. It's never. I mean, you can count on one hand the number of elections where health has been a manifesto issue on any of the African countries. So it's orphaned, it's neglected, it's considered inconsequential. Now, that's something that I would hope that the experience of the pandemic, if nothing else before then, should have changed. As in, we realize that if you didn't know it before, we all know now that if health isn't sorted, if the health system isn't in order, everything else can fall apart. But whether that lesson has truly been learned, I'm myself a pragmatic optimist usually, but with this one, I'm more veering towards the pessimist side. I don't think the health system still orphan health in its broadest sense, not just in the healthcare delivery mechanisms, is an orphan topic on the continent. In the UK, you can't win a local election if you don't have a point of view on the health system. You can't. You have to have a point of view. So the electorate there will hold you to account. Our citizens, and you name whichever country you are, you're talking about, maybe one or two exceptions, don't actually realize that health and access to health and the infrastructure to enable them to seek the best quality health experience in their lives is a political responsibility, and it's one that governments owe them. So they don't hold governments to account, and therefore governments don't bother. So yeah, that I think that the key challenge is the fact that health is orphaned. It's the responsibility sits on individuals and their families, and that's why we talk a lot about remittances and the amount of funds that the diaspora remits back to Africa, but that almost always goes to individuals for managing significantly health challenges that shouldn't be a problem if the electorate and therefore their elected governments actually took ownership of the duty to deliver a positive health experience. I mean, you only need to look at the Abuja Declaration, which is almost 30 years old now, and we still, granted, you can argue about whether that 15% level was a practical one, 15% of your annual budget, and what is health expenditure as defined in that statement. But nevertheless, we haven't spent anywhere near that amount. I think there's only 2 or 3 countries at one point who've managed to reach that. So I think orphaned is the term I would take.
I think you've also made a very important point with respect to having a diverse health system. Some in the early phase, others in a relatively better position, and also the issue of political will. I think is very very important, as you've highlighted. As usual, citizens are more concerned about daily economic issues rather than health. So they want policies that will directly bring some financial relief to them, immediate financial relief, and I think that is something that we have to look at. I mean, we've looked at uh, health systems in the African context. I want us to also talk a little bit about leadership and representation in global health.
Mm-hmm.
I know that it's not only in Africa, but in the context of Africa, what barriers do women, particularly, women in the global health space face in achieving leadership positions in global health, and how do you think this can be improved or overcome?
Okay, so a few weeks ago, if you'd asked me this, I would have said, oh, well, the studies show that we need more education, we need more mentorship, we need more networking, we need more this, we need more that, women need to do that. There was the American movement to sort of, leaning in and all that. But actually, I think that the barrier, the fundamental barrier is the system. The system is designed to keep women out. That is pure and simple. So it doesn't matter how much we increase the educational opportunities for women. It's important, but it's not sufficient. It doesn't matter how much effort we put into leadership courses, and we need to make sure, of course, that the right leadership courses, not that my first experience of one. I must say that subsequently, I had much more positive leadership development experiences than that very first one. It's not just about making ensuring that women have access to mentors and sponsors and such like. Those are important but not sufficient. We need to actually look at the system within which those women then have to operate, and if that system is as it is, and I think this applies whether it's in Africa, in Europe, North America, in Asia, the system is designed by and for men. And so, for women to really be able to get into the system, be leaders in system, stay and be successful in the system, that system has got to be changed. We've got to make it one that is designed for men and women equally. That means that the
The
system
system
needs to
needs to
consider
consider
not
not
just
just
as
as
a
a
nice to
nice to
have
have
extra
extra
that you
that you
tag on
tag
at
on at
the
the
end.
end.
From
From
the
the
beginning,
beginning,
who what
what
are the
are the
needs
needs
of
of
every
every
person
person
who
who
should be
should be
part of
part
the
of the
leadership
leadership
narrative in
narrative
this
in this
space,
space
and
and
build it
build
in.
it in.
And
And
it's
it's
not
not
a,
a,
I was at a women's conference once, I won't mention which one, a few years ago, where in the room they're talking about, how do we enable women to participate in leadership and be represented in the workplace. And a very well-meaning young man stood up and said, I help my wife to look after the kids so she can do her when she has to go to work, or when she was doing her exams. I help my wife to look after the kids. I get them ready for bed so she can study. And he got a round of applause. And then me being me, I stood up and asked him, I said, they're your children too, aren't they? You're not helping your wife, you're doing your job. And if you're just helping her the odd day a week, you're not helping. You shouldn't. You should be. The responsibility should be shared and owned equitably. So that's what I mean about the system, where you just give a little bit and say, okay, we're making it. We're helping you women to get into leadership positions. That
that
doesn't
doesn't
work.
work.
And if
And
you
if you
don't
don't
change the
change the
system,
system,
those
those
women
women
get
get
in.
in.
And I
And I
can
can
tell
tell
you
you
from my
from my
own
own
personal experiences how hard it is to be the token. Now, when I say token, it's not that you're not qualified, because invariably you might actually be the most qualified in that space, because like our parents told us, if you're black and you're working in the West, you need to be 4 times as good to get half as far. That also, then you add being a woman as well. So there's the intersectionality for being a black woman, where you have to be better than everybody to get in, but then you get into a system that wasn't designed for you to stay there. So there's the talk post-COVID of the Great Resignation. We need to look at, break down those statistics a bit and look about how many women of color are actually leaving because those systems were not designed for them to stay and feel comfortable and thrive in those spaces. So I don't need to repeat all the things about, being access to training, yada, 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 mentorship and all that. My focus is the system. if the recruitment system, if the workplace
place
environment, the
environment, the
policies,
policies,
they
they
don't
don't
allow
allow
for there
for
to
there to
be
be
as
as
many
many
qualified
qualified
women in
women
the
in the
room as
room
they
as
are
they are
men,
men,
it's
it's
going to
going to
fail.
fail.
So
So
we've
we've
got,
got,
we've
we've
done
done
enough of
enough
the
of the
ticking,
ticking,
jumping the
jumping the
hoops and
hoops and
saying,
saying,
get this
get this
amount of
amount of
degrees.
degrees.
Been
Been
there,
there,
got
got
those.
those.
Get these
Get these
mentors,
mentors,
network,
network,
that you
you
tick
tick
all
all
those
those
boxes.
boxes.
And
Yeah.
And
still,
still,
let's
let's
look at the data from the
the
Beijing
Beijing.
Declaration. At this rate of change, my great grandchildren will still be dealing with the imbalance of women in leadership in the health system. So we've got to change that system. And it's the same, it's not just an African issue. That system, it may, the veneer might be thicker in other regions of the world, but the same challenges exist, that the system wasn't designed for women to be part of it, not in a leadership position, definitely. And until we change that, we will, you'll just have women who come in, fight all the hurdles getting, and then they just burn out and crash because they're constantly beating their heads against the wall.
Yeah, yeah. I think this is such a profound revelation. You've highlighted several crucial points. You've also mentioned the importance of mentoring and capacity building, and even when that is done, there's still a barrier to um, getting to to the apex of your career. Um, but when you talk about a system, what specific areas of the system, what really are the essential elements that need to be remodeled or changed in order to ensure a more equitable distribution, for example, in leadership roles?
Right.
Right.
So if I had a magic wand, I would wave it and change the mindsets of all the men in the system. Even my experience, and there may be others who have a different experience, but this is my experience. My experience is even the most well-intentioned men
Men
in
in
leadership
leadership
positions
positions
have
have
that
that
little,
little,
often
often
unconscious
unconscious,
Yeah.
or
ingrained
ingrained
perception
perception
of
of
this
this
subsidiarity of
subsidiarity of
women to
women to
men.
men.
Mm-hmm.
So
So
we
we
in
in the
the equity movement need to focus some of our re-education on the men, and it's not just about men being allies. It's actually men actually doing the work. So in the racism conversations, we talk about the fact that white people need to do the internal work to understand their own role in the status quo. It applies also in the gender inclusion argument that even the most intentioned men need to do the work to recognize where their biases might actually be a part of the problem. So that's one. And then while we're working on, another, I'd like to drop names of people I admire. John Amechi is a former NBA basketball, US basketball player who is a work psychology of the workplace expert who I hugely admire. And he's on LinkedIn and or Twitter a lot. So if you don't know him, I recommend you go and look him up. But he talks about the fact that he said it doesn't really matter if people have unconscious biases if the system is right, because the system will stop those unconscious biases from influencing the outcomes. So that means that we have to build into those systems policies that say very categorically recruitment should be blind on gender or race. The
the
workplace
workplace
should
should
allow
allow
and
and
enable
enable
for
for
people's
people's
different
different
biological
biological
needs.
needs.
The whole of society benefits from the biological function of childbirth, which sits with women. So why is the workplace not designed for that to allow that to happen? And why should a woman be penalized for giving birth to people who are going to pay your pension, my pension? So dealing with the biases is one aspect, but making sure that the system doesn't allow those biases to influence outcome. So that's about, office place policies. We know that it's so much about gender-based violence in the educational systems, in the workplace. Those are key factors that take qualified women out of the workplace and they don't stay. But then also we then go back and this is where we have to, because much as we talk about the positive benefits of the culture, that the various cultures on the African continent, we also recognize that there's some very negative practices in our culture that need to be addressed. And I would argue, and if a few years ago we had a side event on the historical role of women in leadership on the African continent, where Professor Ngozi Achebe, she's a historian in the US of Nigerian descent, the child of Chinua Achebe, the author, gave us a masterclass on the pre-colonial role of women in African society, and how a lot of what we call traditional roles of women in Africa today are actually Victorian colonial imports. So if we go back to our history, those roles are not necessarily there. But then we do need to also acknowledge that there's some things that are in our cultures that need to change. Culture is dynamic. It's not set in stone. So the fact that if we think about it, I think it was Chimamanda Adichie who said that, a few decades, a few hundred years ago, they used to kill twins, but we don't anymore. So if the culture's evolved to not do that, so why can the culture evolve to not ban women from the public space because they're on their periods? And again, I would use an example in the UK for where Viagra is, I believe, now available over the counter because it's a male issue, but there's restrictions and access to contraception that women use. Research. If you think about it, the amount of funds going into research on issues that concern men is disproportionate to that goes into. So look at endometriosis. Endometriosis is so widespread in and we're not doing research into that. So it's about the system. You have to ask yourself in every aspect of the system, where is everybody who should be part of this question and the solution? And if we make a habit of doing that and then saying, so how do we need to design it so those people can engage? You just need to think about physical disability, for example, and access to buildings, for example. I was in an online thing where I was reminded of my own bias, where I have a very loud voice. And so when the microphone wasn't talking, I went, that's okay, I have a very loud voice, I can talk. Totally failing to recognize that the microphone enables somebody who's hearing impaired to use their hearing aid to hear me better. Somebody made a comment on that. And since that time, I make a conscious point of making sure that I ask for the microphone if it's there, in case there's someone who needs it. But we should build that into the system where it says every conference, webinar thing where you have speakers should consider and assume by default that there are accessibility issues for others, because we have the solutions to address that. So it's about actually making it so that people's conscious or unconscious biases become inconsequential. They've done blind recruitment, for example, where you don't put those factors that indicate whether an applicant is white or black or male or female, and shown that it doesn't therefore matter if the person doing the shortlisting is biased, if you create a system where they can't see those factors that will allow them to be biased. Although it's, you should note that it's not just whether you tick the gender box or your race box, even that can give clues as to whether you are white, black, male or female. So there needs to be thorough work done to make sure that when you're actually doing gender and race blind recruitment, that you really consider not just the tick box of gender and race, but also other pointers that might lead a biased selector to default to their biases and preferences. I could go on, but those are a few examples of
I can see how you're passionate about this particular topic, and it's rightly so. I think that, as you've said, institutions have to change. The mentality has to change for us to see a significant improvement in this. Enlightening conversation, and I'm learning so much just by engaging with you this couple of minutes. But I mean, looking back in your career and what you continue to do, what are you most proud of in the things that you've done? What are you most proud of?
That's easy. And it's a
And it's a
generalization, but
generalization, but
it's
it's
easy.
easy.
I'm
I'm
most
most
proud
proud
of
of
the
the
young
young
women that
women
I've
that have
had
had
the
the
honor and
honor and
privilege to
privilege to
mentor.
mentor.
Mm-hmm.
They know
They
I
know I
call them
call
my
them my
retirement
retirement.
plan. Um, I mentioned already that too often you're the only black only woman in the space, and so the women that have had the
Had the
honor
honor
to
to
support in
support in
various
various
ways through
ways through
mentorship
mentorship
and etc.
etc.
Just
Sometimes
by
just by
being
being
a
a
navigator.
navigator.
Mm-hmm.
I
I
keep saying
keep
to them,
saying to them,
we're
we're
not going
not
to
going to
solve it.
solve
The
it. The
next
next
generation,
generation,
they're right
they're right
behind them.
behind them.
They're
They're
going to
going to
address
address
this
this
because
because
that
that
is
is
easily
easily
the
the
thing
thing
I'm
I'm
most
most
proud of.
proud
I'm
of.
not
I'm
going
not
to
going to
name
name
any
any
names.
names.
Those who
Those
know
who
me
know
know
me
who
know who
they
they
are.
are.
But
But
there's
there's
so
so
many
many
amazing
amazing
women
women
with
with
the,
the,
like I
like I
said,
said,
they've
they've
ticked all
ticked
the
all the
boxes on
boxes
those
on
things
those
they
things
say
they say
women need
women
to
need
do
to
to be able to succeed,
succeed,
and they're
and they're
doing
doing
more. They're
more.
the
They're
ones
the
that are
ones
going
that
to
are going to
break
break
down the
down the
system that
system
we're
that we're
struggling
struggling
with
with
and
and
make
make
it
it
impossible
impossible
for it
for it
to
to
remain.
remain.
So
So
that's
that's
easily,
easily,
I'm
I'm
most
most
proud of
proud of
having
having
whatever
whatever
tiny
tiny
influence I've
influence I've
had in
had
their
in their
careers.
careers.
That's what
That's what
I'm
I'm
most
most
proud
proud
of.
of.
Because
Because
it's
it's
people
people
that
Yeah.
will
that will
change the
change the
system.
system.
Yeah.
It's
It's
people.
people.
Well, mentees, if you're watching us, you know who you are. So shout out to you, and make sure you're doing exactly what
Oh, I
Oh,
Mr.
I
know.
Blair
know
wants
they
you
are.
to do.
I
I
know
know
they
they
are.
are.
Okay.
I know
I
they
know
are.
they are.
Okay, but before we go, I know, especially as you've said, in the field of public health or global health,
Mm-hmm.
sometimes the path can seem so daunting, especially for
Mm-hmm.
early career professionals. What advice would you
Mm-hmm.
offer based on your journey so far?
So it was, I think it's Paul Farmer who he had a much more elegant way of saying it, but the bottom line was that public health is about equity. And so for anyone who I get a lot of people saying, I want to be work in public health, I want to work in global health. The first question I ask them is, do you understand what equity is in that space? Because if your driver is, I want to be the next director general of whatever WHO and all that, that's the wrong that driver. The driver has got to be about equity. And so the first thing I say to them is, you can be part of the global health problem or solution depending on the lens through which you look at it. And if you look at it, and I remember having a conversation with someone who she wasn't very happy, or I think it was she wasn't very happy at the end because she wanted me to help her work, and this was a conversation in the UK, work abroad in global health. And I recognized she actually lived in Liverpool in the northwest of England, which has significant health disparities and challenges there. And I said to him, so what are you doing to address health equity in Liverpool? Do that. That's global health. Global health isn't just what somebody in the global north comes to do in the global south, and we can talk about that whole terminology of global north and global south. We can discuss that on a different day. And you guys have spoken to people who are far more versed in that subject than I am. So the advice I give someone who wants to get to work in global health or in public health is, first of all, know why. So I keep saying that TB was what brought me to global health, and the foundation was it equity, was the fact that the reason why patients couldn't got TB in the first place. So the factors that contributed in getting TB or having
Having
poorer
poorer
outcomes on
outcomes
the
on the
likes
like
of drug resistance
resistance
than
than
sensitive
sensitive
TB,
TB.
whereabouts
Whereabouts
they didn't actually have to do with the health system themselves. Well, even when they did, it's about equity of access to opportunity, to knowledge, to services. And so I think the first thing is to be clear about why you want to do public health, do global health. And then when you're clear about that, people I've had questions about, oh, should I do a PhD? Should I do a GRPH? So first of all, I would say that what a master's in public health gives you is the language to enter the profession, to discuss the topics and terminology. And therefore, I recommend that if you have the opportunity to get a master's, it doesn't matter, it doesn't have to be in London School, Liverpool School, Harvard, all that. A good master's degree that won't break the bank, preferably, um, gives you the language to then enter the conversation. But beyond that, global health is about equity. It's about doing, it's about recognizing, it's about any room you're in, looking around and saying, who is not here, who should be here. And if you take that perspective, your path will you will flow down the path that you need to be in, and you will make a difference. Even if it's, whether you're working at community as a community health worker or you're the director general of WHO, it's got to be about the lens through which you look at the problems. And for me, the most comprehensive is about equity.
Thank you so much. Thank you so much for ending on that note. I think this has been a very insightful conversation, and I'm truly glad that you're able to join us on this episode of the Global Health Uncensored. Um, Thank you so much for your time.
Thank you.
Regards to everybody.
Thanks for having me.
Yeah.
Yeah.
To my viewers, you've seen the kind of content you're having. We're going to be having series of contents on global health, specifically in the context of health systems in Africa. So stay tuned for the next episode. Thank you so much.
Great.